This is related to the first module, the golden hour management. This is an easy question, but in terms of application, I would ask you to elaborate each one a little bit. Which components of the golden hour management affect the respiratory adaptation and management? So we have delayed cord clamping, thermoregulation, asepsis, communication, and all of the above. So who wants to take the question?
So can I answer?
Yes, please. Dr. Virender.
So the answer is all of the above.
What I would say is you speak on one aspect of it and we'll pass on to the next one.
Okay.
You can choose whichever you are most comfortable with.
So I'll start with the first one only, delayed cord clamping.
Yes.
Yeah. So delayed cord clamping is like delaying the clamping of the cord for at least 60 seconds. And this helps in, more transfer of blood to the baby. It has been found with the reviews and with the meta-analysis, and particularly in respiratory adaptation, because it gives extra blood volume which goes into the respiratory vasculature with the pulmonary vasculature, and even in cases where the baby is not crying and there is some chances of asphyxia, I would say, even then the delayed cord clamping is even more important in those cases. Although the recent the textbook says that if there is a requirement for resuscitation, you should immediately cut it and go to the center. But now the new trials are being done.
You have the new update from AAP as well, except for the extreme premature babies, you can do cord milking. Apart from the extreme premature, you can do cord milking in that scenario.
Yes, cord milking can be done.
The hemodynamic stability is crucial, and that is why this becomes very important. And cardiopulmonary is together. The heart and the lung work together. So the vascular filling, and thank you for elaborating. Dr. Rakesh, you want to take the next point? Please, camera on if possible. Yeah, please.
Appropriate and timely communication, sir.
Okay.
To the mother and to the father or a family member, we should tell them like baby is preterm and needs this kind of resuscitation and NICU care. And to the staff, we should brief them like how to maintain asepsis and how to, if baby is not crying or if upgar is low, how to handle, like how to use oxygen and blenders and the baby pap, how to use it, and educate all the staff members. And then if baby is heart rate is low, how to manage.
Yeah, so you'll be basically communicating on all aspects, including, you have to plan ahead. If you need surfactant in the labor room, for example, who will bring it? Because all of you may not be bringing the surfactant to the labor room. It's an expensive medication, but there are some cases where you may need to bring it. So planning manpower is important. Who will be present with you? Who is available to come immediately to bring additional things you may need? And of course, as soon as baby is born and you're stabilizing, you try to inform the NICU that this baby is coming on CPAP or needs intubation and everything else. So have a system in place. So thank you, Dr. Rakesh. Dr. Prateen, I think you want to comment?
Yes, sir. It's, another thing that it has to be a very good thermoregulation.
Yes.
Immediately after birth, the baby has to be wrapped with polyethylene plastic. Also, we should do a pre-warm the incubator or warmer and immediately shift the baby to the warmer if it's available in the delivery room, or it should be shift to the nearest NICU with the proper maintaining the thermoregulation, because it prevents just the hypothermia, the hypoglycemia, and meanwhile should also maintain the asepsis as well.
So thermoregulation is crucial. In the respiratory point of view, among all these, if you want to group them in terms of importance, I would put thermoregulation at the top, because poor temperature maintenance affects directly the surfactant recycling, which we discussed last time. there is a higher risk of pulmonary hemorrhage in a hypothermic baby. There is a higher risk of PPHN in a near-term baby with hypothermia. So that's why, I mean, Dr. Satyan has demonstrated in his study that when they are trying in meconium aspiration to cool the babies, many of them show hemodynamic difficulty in transition, the PPHN-like situation. So thermoregulation is critical. You don't maintain the temperature well, you're making it much more difficult for you in terms of lung care. Who else wants to comment on the last point, asepsis? Is Meera here today? I don't think she's there, right? Dr. Janika, do you want to comment?
This is
Please
very
unmute.
important.
Yeah, or asepsis. What is the importance of asepsis right from the golden hour? And the labor room, you're handling quite a few different things, isn't it? I mean, you're touching the surroundings of the baby much more commonly, and the baby is wet, so sticky. So the colonization is contributed a lot. One of the main aspects you need to monitor your team, whether they are doing it, is changing the gloves. I mean, suppose you're moving the baby's cot to the NICU. As soon as you reach the NICU, change the gloves immediately before you take the baby to check the weight and put the incubator. So this aspect is often missed. You're holding the incubator, pulling along the radiant warmer or incubator, and when you go there, you start handling the baby with the same hand. So change of gloves is important. Another important point to stress, if you are busy, don't worry about changing gloves. You can use alcohol gel on the gloves, just like you use a hand rub. So you don't need to change the gloves immediately if you don't have time. You can use hand gel on the gloves. So remember that it can be done as well. Dr. Rakesh, you wanted one more comment, is it? Or you put your hand down again? So we'll move to the next question. A high compliance chest wall in the newborn contributes to significant chest wall recessions in babies with lung disease. So the question is whether it is true or false, and I would also like you to elaborate on that. So Dr. Nishant, do you want to take this?
Yes, sir. I think this is true, sir.
Okay.
So as if the chest wall is very compliant,
Yes.
so then it will be prone for recessions, because the chest wall is cartilaginous, and when the baby is breathing fast also, so to expand the lungs, baby is breathing fast, and as the chest wall is compliant, we will see more recessions in that case.
We are talking of baby with lung disease most of the time.
Yes,
so
sir.
the lung is stiff and the lung tends to close down. So the chest wall is supposed to hold it forward, like Dr. Akansha was discussing. So the pull of the lung is not countered by the chest wall. Being a soft chest wall, it's going in with the lung. Okay, that's the reason we get complaints, and that's why the positive pressure that we give with CPAP and non-invasive ventilation may counter that. I mean, you're trying to balance the airway closing down or the chest wall closing down with that. So the lung is closing, lung is pulling in, the negative intrathoracic pressure is high, and the chest wall, which is high compliance, that's why you see the indrawing very prominently. So thank you for answering this. So in this question, I mean, it's about matching the correct responses. So the reason I asked Dr. Avneet to present that slide in the end is so that you get a clue for this. So just to look at the questions and see which one, I mean, so you can try to match it. It's not difficult, but you try to use get familiar with the unit that we are using as well. Try to think about how the unit is coming up here as well. So let's see who wants to answer. Dr. Saravana Raja, do you want to apply?
Good evening.
Good evening.
The tidal volume is 5 to 7 ml per kg, sir.
Very good. So you went
Tidal
from
volume is the
easiest to
volume of
first.
air goes in and out for during normal respiration.
Good.
And then a functional residual capacity is 22 to 30 ml per kg.
Perfect.
It is a volume of air left behind after normal respiration, sir.
Okay.
Then resistance is 1 to 2 ml per centimeter water.
Now think again. You attended the talk by Dr. Akansha.
So it's 1 to 2 ml per centimeter water.
No, that is what?
Sir, complaints, sir. Complaints.
Yes. Yeah.
Complaints. So complaints is nothing but the change in volume by change in pressure.
So that's why the unit is ml per centimeter
ml
water.
per centimeter water.
Okay. And
resistance is 25 to 50 centimeter water per liter per seconds.
So the reason the resistance has this unit is because it depends on different components. You attended Dr. Razak's lecture where he talks about the formula and the law guiding resistance. So obviously you involve many components in that. That's why you have the unit liter per second as well, the volume as well as the time. Okay. Well done. Any questions on this question? Have you understood the basic units? And anyone else wants to comment on this question? Dr. Kamaldeep?
No, sir.
Okay. You'll be coming to time constant as well. So you'll be looking at the interaction of compliance and resistance in that. So this is the clinical measure which is most likely to help. Of course, you need to carefully evaluate a baby who is deteriorating or for the different aspects. This is a premature baby on non-invasive ventilation, and the nurse is reporting repeated desaturation episodes following apnea. So you can have increased pressure delivered on the non-invasive to try and recruit the lung volume, which is lost during the apneic episode, and maintain the FRC. Urgent blood gas analysis, increase FiO2 to 20% more than the current requirement. Start IPPV or all of the above. So let's see who wants to take that. Dr. Ajeshwar, do you want to answer?
Yes, sir. Like in this question, they have asked about a baby on NIV with repeated desaturation episodes following apnea, and all the measure which I mentioned in A, B, C, D, E are important depending upon the clinical situation of the body. First of all, like we increase the pressure delivered on NIV.
Your choice. I mean, do you think it should be E or any one of the options? I would go for one of the options. Then what would be your option?
E, sir. E, all the above.
I mean, with the given information.
But sir, it should be a sequential thing. But if I want to pick among all, I would go for A first.
Yeah. So just go with A in this case because you don't have the full clinical scenario, and doing everything else would be overdoing in this case. Okay. So you have to be practical.
In the question, it is asked with repeated desaturation episode following apnea. So
yes.
After we go for this option, the next options are also true, but the most reasonable would be A.
Yeah, the blood gas would not be done urgently in most of these cases. If they don't improve, you can consider a blood gas. And FiO2, you don't usually go up to 20%. So normally we suggest 5 to 10% more than what's the current requirement. You don't want a risk of ROP. And IPPV is only if the baby is not responding. And I mean, obviously you don't want to ventilate. So that's why I put the choices which are not going to be the most appealing. So E would be the wrong answer here. I would go for A as the most likely, because you obviously know two of them are not appropriate. So when you choose MCQs, your answer choice should be what's the most relevant. And obviously you can't get into the mind of the person framing the question, but you have to try and reason out, are the other choices all appropriate or not? Even if one is not appropriate, I would not go for all of the above. Okay.
Right.
So we have two choices here which are probably not appropriate in the routine sense. So I wouldn't go for E. I would go for one of the two options in the beginning, which again, the first option was discussed in the discussion by Dr. Avneet. So that would be the more likely one. I think Dr. Gaurav wanted to make a comment, is it?
No, sir. No.
Okay. Anyone else had wanted to comment on this? Dr. Priyadarshini, do you want to comment?
No, sir.
So what is your view? I mean, when would you do a blood gas in such a baby? How many of you do regular gases on a baby on non-invasive ventilation? Most of us are moving away from blood gases to guide non-invasive. So your impression is to assess whether the baby is tolerating the non-invasive ventilation or not. And then you decide on the support needed based on the retractions and the oxygen requirement and adjustment. Obviously, you would consider an X-ray according to your unit policy. I mean, the gas according to the unit policy, but routine gases are not indicated. And when you have desaturation episodes, your clinical evaluation should guide you. Is there infection? And one of the points I would like to make here is that a baby who has hypoxia due to recurrent desaturations becomes a bit floppy, especially if it's a premature baby. They have, I mean, the hypoxia affects the brain's functioning for a brief time, and this is not permanent or anything, but these babies are quieter, and the desaturation or the apnea itself leads to mottling. So you may overdiagnose sepsis if you rush to do the things, but if you increase the pressure, allow the baby to settle down, provided the baby is not deteriorating rapidly, you can give it an hour or so to close monitoring and then decide whether you need sepsis screen or start antibiotics. So that again, you can go with the nurse's judgment if it's an experienced nurse as well. So the last question is, which of these statements regarding time constant is incorrect? So we didn't discuss time constant here, but Dr. Razak in his second talk had discussed time constant in quite detail. So I hope all of you had watched the lecture. The time constant is short in low compliance lung disease like RDS. We need at least 3 times the time constant as a minimum time period for adequate expiration. Time constant is short in conditions with increased resistance. A long inspiratory time in a baby on high rate ventilation may leave inadequate time for expiration. And time constant is a product of compliance and resistance. So again, we can go. Dr. Priyadarshini has her hand up, but if possible for anyone else who has not commented so far, Dr. Bindu.
Yes, sir.
Do you want to answer?
So the first option is the time constant is short in low compliance lung disease like RDS is correct, sir.
Okay.
It is a true thing. And we need at least 3 times the time constant as a minimum time period. That I am not sure, sir.
Okay, Dr. Priyadarshini, do you want to comment on the point too?
Yes, sir. Actually, we need at least 3 to 5 time constant as a minimum time period for adequate expiration, sir, to prevent air trapping.
So that's true as well.
Time constant is actually longer in conditions with increased resistance because it's directly proportional to resistance, sir.
Okay, I mean, who is the other one speaking? Do you want to take the next point?
The long inspirated time in a baby on high rate ventilation may leave inadequate time for expiration. That is correct, sir.
So can you give a practical example of this? Which mode of ventilation do we find the problem in this? I know we have not discussed modes, but if you want to comment on it. So in assist control, I mean, obviously the baby's every breath is going to be supported. So where the baby is very tachypnic, obviously the expiratory time may become shorter and shorter. Suppose the baby is breathing 80 and you're on assist control mode, the ventilator gives 80 breaths. Of course, we will discuss it in detail when we come to that. But remember, if a baby is very tachypnic, you need to look at assist control, whether it's the right option or not, till you handle the tachypnea. So the last point, I mean, I heard a male voice. I mean, I'm not able to see the name. So do you want to speak up?
So I was telling, time constant is the product of compliance and resistance. This is the right statement, sir. This is also correct. The only wrong option was C option, sir.
Yes. So I hope this concept is clear also. Remember that most newborns need a short time constant unless you're dealing with BPD or meconium aspiration, I mean, short eye time. So we usually keep 0.3 to 0.35 in RDS. And where you're using pressure support mode of ventilations, obviously the inspiratory time is also regulated by the baby. So you only keep the Imax for that, the maximum inspiratory time that you allow. Otherwise, the baby regulates the breathing as well. And the point we made about the rate on PC, I mean, the assist control mode of ventilation is very important as well.